here? Okay. So, good evening from me. Thank you very much for the kind invitations. In the next few minutes, I will present you a case from our cath lab. There is a similar case. A valve case is in a patient with a failed surgical aortic bioprosthetic valve with a small aortic annulus. No conflict of interest here. So we all know the causes of the valve dysfunction. The most common cause we all know is the structural valve deterioration, as we know from the studies. Also, studies demonstrate that in 10 years from the valve, the degeneration of the valve is about 30 to 35% from subclinical to clinical relevant significance. So we go with our case. So we had a male patient of 84 years old. He had a surgical aortic valve replacement due to severe aortic stenosis about 14 years ago, 2010 in Australia, where he used to live. He had a LabCorp porcine valve of 21 millimeters. This is a valve with a special characteristics we will see at the next minutes. And from the non-cardiac medical history, he had COPD, he was ex-smoker, and he was also an ex-alcohol abuser with esophageal varices. So, the patient presented with symptoms of heart failure, NIHA class 2 to 3. He had several hospitalizations the last 2 months due to heart failure decompensation with pleural effusion, fatigue, and dyspnea. From the coronary angiography, we had no significant coronary disease, but as you can see from the artography here, he had a severe aortic regurgitation. So the next question is valve TAVI or redo in this case. Studies, of course, we don't have a randomized trial for these cases. Meta-analysis, systematic reviews, and meta-analysis from JAHA 2022 shows that the short-term results for hard clinical endpoints, mortality in the first months, is a little better for the valve-in-valve TAVI than redo the case. But in the midterm mortality, the results are similar. Of course, the researchers say that we need, of course, more randomized trial to see how we have to deal with these cases, especially in low and intermediate surgical risk patients. However, our patient, as we can understand from the medical history, it's of high perioperative risk. So what the guideline says in this case, if you have a high perioperative risk patients, you can go with a 2A and the level of evidence B with a valve-in-valve TAVI in this case. That's what we do in this case. So in the pre-TAVI screening, we had, as we see, okay, we have the marker. As we see, we have an average of 20 millimeters annulus. We see the calcification of the bioprosthetic valve here, and the high of the coronary arteries was good enough, I can say, from the left main, for the left main and for the right coronary artery. However, we had an impression that this valve was subannular implanted or very low implanted. In the next slide, we can see that the special characteristic of this valve is that has no fluoro markers. This makes the case more difficult to us, as we can see. Okay. So we have no markers at the valve here. From the rest of the screening, the annular angulation was fine, 41 degrees, and for the access site, the bifurcation was fine in both sides of the femoral artery, so we went from the right at this case. Good dimensions in both arteries. And the next question was balloon or self-expandable valve in this case. So the studies, we have no, of course, randomized studies with hard clinical endpoints. However, the only study we have available is from France, the Lytton study, with echocardiographic endpoints. Especially in 1 month, this study says that we have some better results from the Doppler, from the echo with the self-expandable valve than with balloon expandable valve. And 1 year results in the same trials shows that the results remain the same. However, we have to say that the invasive measurements during the procedure in both valves, in self-expandable and balloon expandable valve. In this study, we speak about SAPIEN 3 or SAPIEN Ultra and Medtronic Evolut valve. The invasive data was similar in both valves. So, for the procedure, we decided to go with an Evolut 26 mm. We oversized the valve due to the regurgitation, due to the severe regurgitation in this case. And of course, we have the ability to reposition and recapture the valve in this case, or even more to abort the case if unacceptable result was seen during the procedure. We had the various attempts for the optimal projections, as we can see here, okay, to find the better implanter view. So we aimed for the beginning, from the beginning for a deep implantation in this case. We didn't have the markers. We wanted to stabilize the valve, so we went very deep in this case, as you can see. But, excuse me, as you can see at the right of the presentation, we had a very nice result from the final angiography. So, in the follow-up, no bundle branch block, no conduction disturbances. After 1 day in the CCU, the patient went to the floor and he discharged 4 days after the procedure. So, at the considerations and the conclusions, there is an increasing number of surgical implanted bioprostheses which will require reintervention for structural valve deterioration. Suboptimal previous surgery in this case limits our options. Too small surgical valve, it's not acceptable. The surgeons should go for a root enlargement in these cases. And if the valve is too low, the surgeon has to deal with this. In this case, we demonstrated that a repositionable and recaptured valve device gave us the safe abortion option. Thank you very much.
Okay, thank you very much. Any comments from the moderators?
Yes.
Dr. Sotiris, we have a patient with AR with mild calcification. For stability view, what do you believe that is the most appropriate valve? Balloon expandable, self-expandable?
Yes.
For this?
Yes. As I mentioned before, we thought about this, we talked about this in the heart team, and we decided to go with a balloon expandable. We oversized more, we oversized the balloon expandable valve. As you can see, the annulus goes 20 millimeters, and we took a 26 millimeters valve, Medtronic valve. That was safe enough for us.
There is a comment from Dr. Arabadzis and from Dr. Pilates.
Yes, just a small note. Both these cases, your case and the previous case from a HEPA hospital, if you remember, both patients have very large femoral arteries, 11 millimeters yours and 20 millimeters, an 88-year-old LD. This was because of aortic insufficiency, of course, and the Corrigan sign, just a small comment.
Dr. Pilates and then Dr. Kilic.
I think the valve you choose was the right decision because LabCorp is a very special valve, as you mentioned. It has very long leaflets, 32 millimeter leaflets. So you are lucky because the sinuses of Valsalva were very wide. So when in 50% of the cases, when you put valve in these cases, you obstruct the coronary arteries. So here you have a small valve, which is 20 millimeter, and you have large sinuses. So you avoid the coronary obstruction, which was very good. The other thing is that if you choose balloon expandable valves, you would have the valve leaflets of the LabCorp overhanging the valve.
Probably,
so that was not a good choice. So you made the right choice for the valve.
Thank you for the comment.
When I saw that the prosthesis was LabCorp, I said that invisible bioprosthesis. This is very important because we did valve-in-valve in mitral and tricuspid position of LabCorp. So I don't understand why invisible prostheses are produced. And we want three important requests from our surgeons. Please put complete rings that we can do valve-in-valve procedures. And second, please put visible prosthesis. And third one is also for the notes are very important in the patient out when you externalize the patient. The property of valve, only for example, just your 2 sentences about LabCorp is very important, very, very important.
Okay. To the next case, thank you very much. So it's again from Thessaloniki, Dr. Arabadzis. Akis always has nice